Soraya, can you hear me?
I can.
Okay, I'm gonna try this one more time, and if it doesn't, then can you quickly try to see, I've made you co-host, if you can, if it works from your side, the live stream.
Okay.
It's very easy to do, right? Let me just
Okay.
try one more time and see if this works.
Sure.
No, it's not working from my side for some reason. Are you an admin on the Arasa page? Soraya, can you hear me?
I'm not admin, but I can quickly get the details, or you can send it to me.
Yeah, no, that's okay. So this is gonna become an issue.
Hey, Jean, I am.
Okay, can you do the live stream then? It's easy to switch around. So if you go to the, can you, wait, let me just make you co-host here. Can you check if underneath in the bottom of the thing, you should see a button next to the interpretation that says more?
Not yet.
You can't see it?
No, I can't see it.
What about now?
No, unless I have to first switch off and then rejoin.
Can you quickly do that?
Yeah.
Soraya, do you see that button next to interpretation that says more?
More.
Yeah, no, this is no. I can't change the host.
I see the share content.
Can you look at,
work?
is there an interpretation button
Hold on.
next to the Q&A and all of that stuff? There should be a button that says interpretation. Can you see it?
I'm on my phone, so let's see.
Okay, that's a bit hard.
Yeah, it's a bit, yeah.
Okay, can you just do me a favor and switch the host back to me, because we need to start.
Okay, can I click on start webinar?
No, change me to host first.
Okay. Hold on.
Next to me, next to my name, click to
Yeah.
more and just change host.
Yeah, I just did.
Okay. Let's for now just start because it's 3.
Yeah.
And then we'll sort this out in a moment while we're busy
Okay.
doing the webinar.
Sure.
All right. We're starting now.
afternoon, colleagues, and welcome to this webinar titled Ending AIDS as a Public Health Threat by 2030, Moving Beyond 2020 and Towards the 2030 Targets, which is hosted by the AIDS and Rights Alliance for Southern Africa, or ARASA in short, with the support from the Partnership to Inspire, Transform and Connect the HIV Response, also known as PITCH, which is implemented jointly by Frontline AIDS, AIDS Fonds, and the Ministry of Foreign Affairs of the Netherlands. My name is Felicita Hikwam, and I'm the director of ARASA. I have the pleasure this afternoon of welcoming you to this webinar from a scorching hot Windhoek in Namibia. That's the sleeveless dress. But I will be co-moderating this webinar today along with Sally Shackleton, who is lead HIV technical for key populations at Frontline AIDS. Before we get started, we have a few announcements to assist with your participation in this webinar. Firstly, this webinar will only be conducted in English and there is no interpretation available. The webinar is being recorded now and will be uploaded on the ARASA website, our YouTube channel, and other social media platforms. This webinar is also now being live streamed on the ARASA Facebook page, and you can feel free to share it on your social media from there. While this webinar is a safe and neutral space for sharing of experiences and perspectives in a mutually respectful manner, we encourage you to be mindful of revealing your personal particulars if you are not comfortable for this to be public. ARASA has a zero tolerance policy for undesirable behaviors, including bullying, harassment, abusive use of language, or aggressive expression of opinions. Anyone who engages in such actions will be immediately removed from the session with no prior notice. In the interest of time, we will not make use of the raise hand function this afternoon or allow participants to speak during the webinar. But we do encourage you to please share your comments, your perspectives, your thoughts and questions in the chat box or in the Facebook comments section. Throughout this webinar, we will engage you using the different and various online platforms. One of these is the Mentimeter platform. And in order for us to do this, we would like to give you the heads up that we will ask you to open a new window in the web browser that you're using and to go to www.mentimeter.com. We will provide you the code for the Mentimeter survey when we get to that part of the agenda. We will also do a Zoom poll towards the end of the webinar to check in with you again on how you have participated and what you're taking away from the webinar. So we encourage you to please look out for the Zoom polls, which will pop up on your screen, and to respond to the polls once they appear on your screen. But before we get into the meat of the session itself and the webinar, a bit of background to this webinar. For those of you who are new to ARASA, we are a partnership of civil society organizations working in 18 countries across Southern and East Africa, which was set up in 2002 initially to promote a rights-based response to HIV. Recently, we have pivoted strategically to anchor our work in the core principle of respect for and protection of the rights to bodily autonomy and integrity in order to reduce inequality, especially gender inequality, and achieve health, dignity, and well-being for all in Southern and East Africa. For us, the achievement of sexual and reproductive health and rights, including HIV prevention, depends on the realization of the rights to bodily integrity, privacy, and personal autonomy. HIV prevention has been and remains a key thematic priority for ARASA. Since 2017, we have highlighted government accountability to HIV prevention targets through our Missing Piece of the Puzzle campaign, which is supported by PITCH. This campaign highlights the need for the elimination of structural barriers to HIV prevention. You can find out a little bit more about the Missing Piece of the Puzzle campaign on our YouTube channel, our social media, Facebook, but also particularly on the ARASA website at www.arasa.org. info. As you know, 2020 is an important year for the AIDS response, as the deadline for the fast-track targets and a commitment to reduce the number of new infections amongst young people and adults in Eastern and Southern Africa by 75% compared to the levels in 2010 has arrived. This presents an opportune time for reflecting on how we are faring in meeting these targets that we set for 2020, but also how we should adjust course for the next milestone moving towards 2030. Recently, with support from UNAIDS, we conducted a civil society consultation on progress on HIV prevention in the Southern Africa Development Community and presented these findings to SADC member states during a SADC meeting hosted in September 2020. The aim of this meeting really was to come up with an analysis of the progress in HIV prevention that would then feed into and present it to ministers of health. But this particular webinar is a follow-up to the civil society consultation and previous meetings that we've had and discussions that we've had with civil society on government accountability for meeting HIV prevention targets. This webinar also offers a platform for us to ponder the questions why targets are important for progress towards 2030 goal, and also how civil society advocacy can be strengthened to increase accountability of governments and other stakeholders, including ourselves, in regard to these targets. This afternoon, we have a very exciting lineup for you, which will help us unpack some of these issues, including an introductory video and framing presentations from dear friends of ours and civil society broadly, which will be followed by an exciting panel discussion of passionate activists representing different constituencies and who are also passionate about the removal of structural barriers for HIV prevention, and will reflect on how they're doing advocacy around these issues, but also how we can innovate and strengthen our advocacy to push towards the 2030 milestone. But before we get into all that exciting stuff, we wanted to check in with you and get a sense of the perspective that you bring to the session. So as I mentioned earlier, we would like for you to open a window in your web browser that you could then type in www.menti.com, and this will allow for us to screen a survey to check in with you about what perspectives and thoughts you're bringing to the discussion, and might also spark some of the reflections from our panelists. So the code that you should use when you get to menti.com is 4605762. It is also on the screen. So right above the question that we would like for you to answer this afternoon, we have typed the instructions to go to www.menti.com and then to use the code 4605762. The first question that we would like for you to reflect on is, in one word, how would you describe progress towards 2020 HIV prevention targets? So from where you're sitting in your community, in your country, in your constituency, how would you describe progress towards 2020 HIV prevention targets? Slow, not fully involved, needs engagement. So there's some reflections that progress is slow, that progress needs much more engagement. Progress is difficult to validate. That is very interesting. Thanks for sharing that. Also remember, you can type in as many words as you like, just as many different words as come to mind when you think about progress towards HIV prevention targets, specifically 2020. Difficult to validate is biggest. And at the moment, actually what that means is that that's the one that was mentioned most frequently. And so the bigger the words are, the more frequently they were mentioned. The smaller they are, the least frequently they were mentioned. So difficult to validate is still the biggest, not fully involved, hazardous, incomplete, non-focused, encouraging. That is very interesting. Need engagement, slow, I unfortunately cannot read or understand what I believe is in French. So if anyone can translate that in the chat, that would be fantastic. But as we mentioned, we don't have interpretation with us here this afternoon. So please, if anybody else could share what or translate what that means. I see, I haven't seen, have it?
It's comme si, comme ça. It means so.
Oh, okay. Let me look at that again. I should know that. Oh, I thought it says commis. Oh, comme si. Okay, there it is.
Comme ça. Like,
I've never seen that. So. Yeah, I've never seen that written down. Sorry. So fantastic. Comme si, comme ça. It's so. You know, it's kind of like in the balance. Uneven. It needs engagement. Not focused. Encouraging. Incomplete. Slow. Hazardous. I think encouraging is the one positive word that has come up. Lots of talk, not enough, as one criticism that comes up. Comme si, comme ça is kind of in the middle. I think I see encouraging on one side, comme si, comme ça in the middle, and then I see some of this kind of like, it needs further engagement, it's not focused, it's uneven, it has stalled, it's difficult to validate. That might also be, you know, a little bit more towards the middle, but hazardous, I think, is on the opposite end of encouraging. Thank you to the 6 people who have participated in this poll and specifically responded to this question. Very interesting to see your responses. We will also encourage the panelists to, in the meantime, you know, look at these, reflect on these, and just think about how this feeds into kind of what you were going to share this afternoon. We will now move on to the second question. And this question is, which word comes to mind when you think about civil society advocacy for government accountability to meet global HIV prevention targets? So what do you think the state of HIV or civil society advocacy is in relation to government accountability to meet HIV prevention targets? A general assessment of civil society advocacy. Are we active? Are we inactive? Are we killing it? Are we, you know, not what it should be? Where you're sitting today, what is your perspective on civil society advocacy for government accountability to meet global HIV prevention targets? Are we doing well? Do you think we're active enough? Is our advocacy strong? Our advocacy is underfunded, that's for sure. Thanks for sharing that, very interesting. The struggle continues, it's improving. Thank you to the 2 people who have participated. If anybody else has joined us in the meantime, please go to www.menti.com and you can use the code that's on the screen and then respond to the question of what comes to mind when you think about civil society advocacy for government accountability to meet global HIV prevention targets. I see that some people actually type their responses in the chat, so I'll also keep an eye on the chat in the meantime. Yeah. Kennedy, I saw you started typing something, but it just says the, but we'll wait to see the rest of that thought. Oh, it was probably the struggle continues. Not putting Kennedy on the spot, but I think the starts with the struggle continues. Still, underfunded is now the biggest word. Interestingly, challenged, engaged, improving are least mentioned, but underfunded is followed by lacks follow through. There's great energy and the struggle continues, and that it's uncoordinated. I think it's such interesting descriptions and also very diverse, you know. So that's quite interesting that there are such differing perspectives on how we are doing with our civil society advocacy for government accountability. Underfunded, lacks follow through, great energy, uncoordinated, the struggle continues, struggling, improving, challenged, and engaged. Thank you so much to everyone who participated in that. We have one last question, just to check in with you on kind of where you are in terms of the perspectives that you bring to the discussion, particularly on HIV prevention targets and civil society advocacy. Last question is, how can we strengthen or improve CSO advocacy for government accountability? So given all that we responded on the previous question, it's struggling, it's underfunded, it's, you know, it's lagging follow through, all of that stuff. What actually can we do to strengthen civil society advocacy for government accountability to meet HIV prevention targets? I don't see anything popping up yet. Okay, no, there's one thing. Engaging funders needs to be done, and engagement in ensuring local health is funded. So that's very much around making sure that civil society advocacy is funded. We need to develop specialized advocates, investing in capacity. So we need to invest resources to strengthen specialized advocates who can increase and strengthen civil society advocacy. There needs to be community-led. Oh, it needs to be community-led and not donor-driven. So going forward, the sentiment is that civil society advocacy should be community-led and not donor-driven. I really have to agree with all three of these because, you know, my experience also, you know, is that it's significantly underfunded. So engagement with funders needs to be done. Oh, thank you. And yeah, we need to make sure that engagement in local level for advocacy is funded. There's a new comment here saying getting better at comms, research, and data collection. Definitely, I also agree with those. So we've had 4 comments on what needs to be done. And these will definitely feed into the panel discussion, because that is also where we're going to go a little bit further into what is needed in terms of strengthening civil society advocacy. But before we close the Menti code, let me just, the Menti poll, let me just read the last comment that I've seen come in, which says we need to be more strategic. We need to work together to address the underlying issues that fuel HIV, poverty, inequality, gender inequality, aid that makes us dependent. Definitely agree with that as well. Thank you so much for sharing. I see that Kennedy's also posted in the chat. And sometimes it's easier than going to the Mentimeter platform to actually just post in the chat. So totally appreciate it, Kennedy. He says, engagement with CSO advocacy should be supported by funders. And that also speaks to the first point around, you know, funders need to be engaged and funding for advocacy needs to be strengthened or increased. Thank you so much, everyone, for participating in that. It definitely helps us set the context and the scene for the discussions that are going to follow, but also it makes us feel like, you know, we are getting to know a little bit more about the people we're engaging in this webinar. So now that we have a better sense of your perspectives on the progress towards meeting the 2020 targets and how advocacy should be strengthened or could be strengthened, we would like to frame the discussion on HIV prevention targets a little bit more. And we will do this using an animation video as well as 2 brief framing presentations. I would like to ask for the animation video to be queued to play now.
In 2015, governments made an ambitious commitment under the Sustainable Development Goals to end the AIDS pandemic. While remarkable progress has been made towards achieving these goals, we are still off track to meeting this target. New infections remain too high, while stigma, discrimination, and violence threaten the progress that has been made. As activists, we need to step up all effort to hold our governments accountable for the commitments they made. To do this, we must listen to the voices of those most affected. It is important that we understand that there are structural barriers that hamper the HIV response, especially when it comes to marginalized communities. These structural barriers not only make it harder to reach the global targets that have been set, but would not make progress sustainable. In the fight against HIV and the well-being and health of all, Everybody counts.
That video has set the scene for where our colleague Maria Stacey will pick up. Maria Stacey is a consultant that's been working with ARASA for years now on our work around removal of structural barriers for HIV prevention. And Maria will do a short presentation for us, which is one of two framing presentations that I mentioned, looking at HIV prevention targets, taking stock and looking forward. Maria?
Maria, we can't hear you. You might be on mute.
Maria, are you there? We can't hear you. I'm
Sorry,
assuming-
everybody, I was struggling to unmute myself. I'm here now. Let's just go to the presentation. So first, let me say, hi, everybody. It's very nice to be with you all this afternoon. It's wonderful, in fact. I really miss the days when we could sit and talk and debate together, but this is a fine substitute. And I also just want to acknowledge Alanka, who's speaking after me. I've done quite a lot of work with Alanka over the years. I've learned so much from him. And indeed, a lot of this presentation actually comes from UNAIDS. And after I've presented, he's going to be adding and supplementing and deepening what I'm presenting in this presentation. And what I'm going to do today, I'm just going to speak for about 10 minutes, and it's a 101 on very brief introduction on what the HIV targets are. And now that it's 2020, and you know, a lot of the targets were due this year, just taking stock on where we are in East and Southern Africa and looking forward to the next 5 years and the next 10 years. So you've probably seen this before, but this is really just to get us all onto the same page. The story starts with UNAIDS fast track strategy from 2015. And the overall goal is for us to end AIDS by 2030 as a public health threat. Now, ending it as a public health threat doesn't mean that there's absolutely no HIV infections in the world. But if we have under 200,000 new HIV infections, that's considered to have ended AIDS as a public health threat. You're all familiar with the treatment targets. By 2030, we aim to have 95% of people who are HIV positive will have been tested and know their status. 95% of people who are positive will be on treatment, and 95% of people who are on treatment will have a suppressed viral load. And then both in 2020 and 2030, the aim is for zero discrimination, because any case of discrimination is a case too many. So in order to reach the 2030 targets, UNAIDS argued back in 2014 that you need to front load your investment. So you need to act now in order to get on track to end AIDS by 2030. And that involved setting 2020 targets of 90-90-90 and reducing new HIV infections to under 500,000 by the year 2020. There were some expanded fast track targets. There were 10 altogether. And I'm just going to pick out a few which are relevant to the work that most of us are doing, which is on structural barriers, key populations, community-based responses, and so on. So the one, number 3, was to ensure access to combination prevention for key populations, at least 90% of them by 2020. To eliminate gender equalities and end all forms of gender-based violence, to end all forms of violence and discrimination by 2020. Now think about that as an ambitious goal. And to ensure that 90% of young people have the skills and knowledge to protect themselves from HIV and have access to sexual and reproductive health. Next one. To ensure that 75% of people living with or at risk of HIV benefit from HIV-sensitive social protection. This is an important one for our purposes, to ensure that at least 30% of all service delivery is community-led by 2020. And number 9, empowering people living with and at risk of HIV to know their rights and to access justice and legal services to prevent and challenge violations of human rights. Now, the HIV prevention goal had 5 HIV prevention pillars, and that was that 90% of key populations and 90% of adolescent girls and young women should be reached with combination prevention, strengthen national condom programs, dramatically scaling up voluntary medical male circumcision, and also rolling out to 3 million people in the world PrEP, pre-exposure prophylaxis for groups at high risk. Now, I think most of you probably do understand this, but just to reinforce that, you know, UNAIDS, as the joint program on AIDS of the United Nations, has a lot of convening power, but they can't do it alone. So they need governments, they need donors, they need civil society. So in 2016, the countries of the world came together in New York and issued this political declaration on HIV and AIDS, which actually includes a lot of the fast track targets that we've just that I've just shown you. And what that did is it meant that governments had actually committed. They'd made a commitment to invest in meeting those goals, and that's important for us as advocates who work on accountability. So 2020 is here, and where are we now? I'm going to look at all of these graphs that I'm about to show you are taken from the UNAIDS 2020 report. And I'm specifically going to show you the graphs and the figures from East and Southern Africa. So in terms of AIDS-related deaths, we've done pretty good, in a total coming down by 49%. Not as far as it needs to be, but it's not bad. Less well at preventing new infections, although East and Southern Africa has done better than any other region in the world. We've only managed to reduce new infections by 38%. And when I say 38%, that's the percentage changed from 2010, which is here, and 2019, which is here. So who is most at risk of new infections in East and Southern Africa? As you can see, most of our, this you know, most of our new infections are in the general population, but over 25%, over a quarter of our new infections are still amongst key populations and their sexual partners. And what you probably also know, but this graph reinforces it, is that we have a female epidemic in East and Southern Africa. And there's certainly, if you look at the pink and I guess that's a dark pink, that 30% of new infections amongst females 15 to 24 and 30% amongst females 25 to 49. So definitely women, and especially younger women, are more at risk of acquiring HIV than their male counterparts. Now, this is a very busy slide. What I encourage you to do is, whichever country you're from, maybe just glance through this and see how your country is doing. So this is the 90-90-90 scorecard. And just for ease of looking at it, can everybody see my pointer? Yes? In the whole of East and Southern Africa, the first 90, we're on 87%. The second 90, we're on 83%. And the third 90, we're on 90%. So we're not doing too badly. If you go through the list, you'll see that countries like Botswana, Eswatini, Namibia, Zambia, and Zimbabwe is close. But those other countries have already met their 1990 goals, which is an incredible achievement, given our context, given the multiple challenges which we face in this region. But there's certainly quite a few countries, and wherever you see orange, or brown, there's cause for alarm. And there's certainly countries like Mauritius, Madagascar, Angola, Mozambique, South Sudan, and even in South Africa, where things are not going as well. So the goal of zero discrimination is still quite a way away. This slide shows you the percentage of, sorry, I can't see my things in the way. The percentage of people who said that they would not buy vegetables from somebody, from a shopkeeper living with HIV. And what you need to look at on this slide, the green is 0 to 20%. The light blue is 21 to 40%. The pink is 41 to 60%. And the dark blue is 61 to 80%. So you see that stigma and discrimination in countries like Madagascar here, Ethiopia, are still very, very high. But in many countries in the region, they are really not where they should be. So, you know, so many years into the epidemic, people still hold stigmatizing, discriminatory beliefs and attitudes towards people living with HIV. Remember, the goal was to eliminate gender-based violence. This slide shows ever married or partnered women aged 15 to 49 who experienced physical and/or sexual violence in the last 12 months. So again, it's a kind of a busy slide, but maybe what you can do is see what color your country is. So for example, like Kennedy, I know, is in Zambia, that would be the yellow. So let's take Zambia as an example. In 2007, 40% of women had experienced violence in the last month from intimate partner violence. It's come down, but it's still almost 30%, right? And there's and here, interestingly enough, I think that's South Africa. It's gone from being very low to being more than 30%. But basically, in no country in the region is it less than 10%. In fact, most countries it's above 20%. So 20% of women experience violence in the last year. And finally, this is also a busy one. Again, maybe have a look at you know, your country and see how they're doing. This is a list of the laws and policy scorecards in every country in the region. And we still have a lot of criminalization and a lot of policy barriers, which are obstacles to us, to people, especially key populations, enjoying human rights and accessing HIV. So for this, the first column is transgender people, where you see red. It's these are countries where transgender people are prosecuted or criminalized. Not too many countries in the region. Criminalization of sex work, on the other hand, it's red, where the countries where sex work is criminalized. It's only Mozambique that has decriminalized sex work. All the other countries has criminalization. Same-sex sex acts. The countries in orange are where you can be imprisoned for same-sex sex acts. The green is countries where there is no penalty. Drug possession, drug use or possession for personal use, as you can see, it's criminalized with a prison sentence in every country in the region. And then finally, let's look at parental consent for adolescents to access HIV testing. Where it's pink, it's that adolescents it's adolescents under the age of 18 cannot, only people over the age of 18 can access HIV testing. The orange is over the age of 16, and the green is over the age of 12. So, looking forward, what happens now? We're almost at the end of 2020. Where do we go from here? There's 10 more years until, you know, 2030 is with us. So UNAIDS is, as you probably all know, is busy working on its new strategy, which will come out in 2021. It's been engaging in a very, very consultative, participatory process, participating with a wide range of people, including communities, including key populations. And all of that is going into the UNAIDS new strategy. What's also going into the UNAIDS new strategy is work that's been done through working groups over the last 3 years to develop programmatic targets for 2025 and to estimate the resource needs. These won't change the 2030 impact targets, but they'll provide updated guidance on how to get there based on the latest research, the latest scientific advances, and current costing of the response. So in the meantime, we don't really have detailed HIV targets like we've had for 2020. So it puts us in a little bit of an in-between limbo stage. But what we do have, and what we do have to remember, is that we have the Sustainable Development Goals. And I'm sure you're all aware of the Sustainable Development Goals for a peaceful, safe, prosperous, healthy society. And these are commitments which have been made by member states, by governments from all over the world. There's a few, and UNAIDS has highlighted, there's a few SDGs which impact on HIV, because as we know, HIV is impacted by so many developmental challenges. So the first one being to end poverty, Goal 2, ending hunger. Specifically, HIV is addressed under Goal 3, which is ensuring healthy lives, and includes the promise made by member states to achieve the end of AIDS by 2030, as well as scaling up HIV-sensitive universal health coverage. The other goals are ensuring quality education, achieving gender equality, promoting economic growth, reducing inequality, promoting peaceful and inclusive societies, and strengthening the means of implementation. So attention to all of these goals is important if we want to end AIDS. And finally, I just want to show you a little video which shows how the Sustainable Development Goals actually impact on people's lives, and how they can make a real impact on the lives of the citizens of the world. So it's just a 2-minute video.
I'm Anna. Let me tell you what the SDGs mean to me. I was born with HIV. When my parents died, my grandmother looked after me. We could not always afford food, but she worked hard to feed us. My grandmother is my hero. She insisted I go to school. I was teased at first, but soon made friends. Today, I'm a nurse and I help others. I wish my parents were alive. They did not have access to HIV medicine. Fortunately, I do. Now, the virus in my body is virtually undetectable, so I cannot pass it on. Meet Leo, my partner. He is HIV negative. He loves and accepts me as I am. And we have been blessed with a daughter, Sophia. I delivered her at my clinic. We just installed solar panels, so we have electricity, clean water, and toilets. Oh, here comes my brother Ben and his partner Luke. They adopted Tina, who's HIV positive. It has not been easy for them to start a family. They had to go to courts to fight stigma and discrimination against them. They are moving to the city where they will be better accepted, have jobs, and good health services. We are happy living in our village by the sea. Life is good. I'm proud. We couldn't have achieved all of this alone without our neighbors, teachers, the government, NGOs, and partners.
Thank you, everybody. Thanks, everybody.
Thanks, Maria. Thank you so much for
Okay.
your presentation and also for sharing that video. We will remind the participants that you can drop your questions or any feedback, responses, reflections that you have on Maria's presentation in the chat box or in the Q&A. Depending on how we do for time, we may also allow 1 or 2 people to speak after Alankar's presentation, but we have to be very careful, and I don't want to make promises that I won't be able to keep. So in the meantime, please do share your perspectives, your thoughts, your responses to Maria Stacey's presentation in the chat, and we will pull on those after we've taken Alankar's presentation. And with that, I would like to welcome Alankar Malviya, who is working with the regional support team for Eastern Southern Africa in Johannesburg, the UNAIDS regional support team. And he has been a long time ally and friend of ARASA and of civil society broadly, and has actually done quite a lot of work with us around tracking of targets and also civil society perspectives related to HIV prevention targets and progress thereof. Alankar, with that, I would like to welcome you to please share your presentation.
Thanks, Felicita. I hope you can hear me, right?
Yes,
okay.
we can.
Perfect. And thanks everyone on this webinar. It's always a pleasure to talk to people working on the ground, people from the community, because I think you guys are the reason why we exist. You guys are the reason for what UNAIDS came together as a joint UN program. So, I mean, it's always a pleasure speaking to all of you. Now, realizing that probably I think we'll be needing a bit more time, I'll straight come to the presentation, and let me start sharing my screen. Can you see the screen? If anyone can just, I think it should be visible.
Yes, we can.
Great. Okay, so I've tried to go through some of the critical issues, building on what Maria was talking about, and especially focusing on the relevant pieces of that information, which you can focus on when you discuss the roadmap for the coming years, and where I think community advocacy is critically important for us. So, I mean, the overview, I'll run these slides a bit quickly. I don't expect you to remember all these numbers or go in details at the moment, but the purpose of sharing this slide, as I've said in previous meetings also with ARASA and the networks, is to disseminate these slides, because the purpose of generating these evidences is that they get utilized. Without utilization, there's no purpose of doing these analysis if they just sit in the cupboards of UNAIDS or of the NACs. So the purpose is to quickly run through these slides, but share these slides also with you and the team for wider dissemination. So, I mean, this is the situation of HIV in the Eastern and Southern Africa. We have around 20.7 million people living. And again, these are all estimates. So I'm taking the median points with 1.2 million children and 12.3 million women. In terms of ARV coverage, as Maria said, that we've made significant progress, so I'll probably not go that much into detail on that. Now, one of the 4 criteria which would probably, which UNAIDS has agreed would define when we say AIDS would end as a public health threat in 2030, was incidence to prevalence ratio, and the target is 3%, which basically means that we'll have 3 new HIV infections per 100 of PLHIVs. Right now, the ASA IPR is 3.5%, and with the target of 3%. So we are doing okay, and that reflects on the encouraging word in the Mentimeter initial slide, that yes, we have we can see light at the end of the tunnel. However, we also know that our region holds the key to the success of the global response to HIV, and 27% of the new infections in the region occurs only in South Africa, while the 7 other countries, Mozambique, Kenya, Zambia, Tanzania, Uganda, Zimbabwe, and Malawi, account for roughly 60% or 59% of the infections. So this tells us exactly where to focus. The progress in terms of reduction of the new infections has been a bit more challenging, as Maria also shared in the slide, with an average of around 32% reduction in the region. And we see certain countries doing reasonably good. So we know what to do. So that's Eswatini, Eritrea, South Africa. But there are also countries like Mozambique, Zambia, and Tanzania, and also Angola's, where you see the infections not declining at the pace that we would have wanted them to be. It's clear that with the current progress and business as usual, we may not be able to achieve what we intended to or what we set as our target. So we would have a huge gap, and as we said, that we'll be falling short of by almost 60%. Now, this slide is also which tells about where the new infections come from and what's the ratio or what's the proportion of key populations in these new infections. Now, I'll pause here for a moment and try and reflect on some of these items that we've discussed. Now, you see, this is modeling. These projections are a model. A lot of countries don't have good data. If you look at this slide, only few countries in our region have data on sex workers, even fewer on injecting drug users or people who inject drugs, and even fewer on people same-sex and LGBTQI community. Now, it's a big problem, because then whatever we are discussing, whatever we are doing, is informed by insufficient data. And with that insufficient understanding of where the epidemic is, what the response needs to be, and how impactful the response is, it's pretty difficult for any one of us, and that probably reflects to first of the I think the biggest point which came out was validation or the lack of validation, or the issues around validation of whether we have done good, whether we are there. So I think that this is something that I would want to underline, that moving forward, we need to advocate at country level to generate data, because unless you record a data, unless you generate that data, it doesn't make much sense to keep demanding disaggregated data by key populations, by gender, by age at the global level. Because eventually every data gets, the first building block of any analysis is the data that gets generated at the service delivery level. So we need to have more advocacy around that to make sure that ministries capture the data, capture all types of population in all their diversities, whether we are talking of from the economic point of view or from the sexual inclination or preferences point of view. Now, this is again reflecting the same. We had in the region only 16 countries reporting this sex worker population. Now, with that, we've seen that the average prevalence is around 36% for sex workers. For MSM, it's 12.6%. But again, only 11 countries out of 22 in the region reported. And then for transgender, it's only one country which reported. Prisoners or people in the closed settings, we've data only from 14 countries. And people who inject drugs, got reported only from 6 countries. So this data that we are seeing is kind of looking the world with one eye closed. You can't have a 3D or a full dimensional analysis of what the problem is in front of you with a 2D picture or with half of the picture hidden. So some of these issues are critically important when you move forward for your advocacy planning for the coming years. Now, if you see, for example, in the region, and Maria's slide also showed that almost like 40% of new infections are coming from the young people in the age bracket of 15 to 24 years. But how many countries are measuring key populations? How many countries are measuring the behavioral characteristics or behavioral parameters of 15 to 18, that group? The age of consent in participation of surveys, in accessing services, in going for reproductive services like abortion services, etc. We know, I mean, the challenges that we are facing. So I think that's where we need to focus our advocacy moving forward, so that we make sure that in 2030, the targets that are set reflect what is counted, and we make sure. So the first thing we should ask in every country advocacy meeting, in every regional meeting to the governments, and we are there to support you, is that if you are setting a target, what is your mechanism to get the data, to make sure that communities will be empowered, will be equipped, or you will have the required ammunition to hold countries accountable. There's no point of having another set of global declarations if communities don't feel empowered enough to hold countries accountable, and they understand from where this data will be coming from, where they can track the progress of the countries. So this is around the adults and girls and young women also. The same issue and exist, and we all know those issues. Now, I'll not go much in detail about the 90-90-90 or the 95-95-95, because that's reasonably on track. But even this is a macro picture, and I hate when we try and generalize these issues across countries. Country have its own peculiarities, and if you'll try and figure out, for example, there's 87% coverage in the first 90. Brilliant. I mean, on a global level, we can go and pat our backs, but are we doing right? Who are these 13% people who are not getting touched by services, who are deprived of the right to health? And you would be we would not be surprised when we'll dig deeper that most of these are one of the most vulnerable sections of the society, one of the most marginalized sections of the population, who are always struggling for their rights. So I think we have to always flip the question. When we say 87% reached, who are these 13% who are not reached? These slides you've seen, and I'll not go much in detail. The human rights related issues continues to hinder the progress, and we all know, and we saw also in the slides that in how many countries sex work is still criminalized, in how many countries homosexuality is criminalized, drug use is criminalized. So we know, and apart from these official or the legal parameters, there is a lot of cultural and the social structural norms which come into existence, again prohibiting people from accessing services, whether it's at the service delivery. And the last thing, which is equally important, is that how much of the financing data is in public domain, how much of community we keep talking of financing at all levels. We keep talking of the need to make the response sustainable and mobilize resource, diversify resource base, have more domestic funding, have innovative financing. But how many of civil society actually get access to the financing data? How many countries produce this data? A lot of countries that I know in the region have at least an average age of NASA, or the age spending assessment, is around 4-5 years old. Some countries don't have robust data. So, just to conclude my talk on this, there are certain issues which I think are equally important when we are discussing this. This item in your agenda, I would strongly urge and encourage you to focus on defining and hold countries accountable for precise definition of what they are going to achieve, whom they are going to address, and how they are going to address. You can only report, as I've said, and I'll at the cost of repetition, I would again say this, that you only report what you record. So unless your recording formats at the service delivery level do not have disaggregation by key population, age, sex, etc., it would be again going through the same cycle that after 10 years we'll keep saying, oh, we don't have data on this. Then timeliness and sustainability is important. I think all the data related, all the data flows in countries should be integrated as per 3.1s in the national M&E framework, and there should be one central authority which coordinates all this. Again, we've had, I think, last 2 years discussing that, and we still have we've been struggling on the issues of structural barriers, and how do we try and quantify them? How do we produce? You would have seen also in the prevention scorecard that countries always have different point of view when certain color coding is given on the structural issues. So I think that remains a challenge. Resource tracking and sustainability remains a big challenge for all of us, I think. How do we collect the real-time data, and how do we make sure that money coming especially from donors is transparently spent? Do we know exactly that how many dollars come in and how many are spent actual on service provisioning? So I mean, these are big question marks that I think we all need to jointly try and answer. And the last thing is also the importance of community-led monitoring. It's a very good, but I think we also have to keep pushing for more resources and more capacity so that we are not challenged on rigor. We are not challenged on its scalability. And so I think the support to communities in the next couple of years is very critically important so that community-led monitoring becomes a success, becomes institutionalized in the systems. And thanks again for ARASA's continued advocacy with SADC and EAC. And we are so glad that in last 3 years, our partnership has really held countries accountable, and we've presented reports at the ministerial meetings. So congratulations to the whole team of ARASA. But I think this is my last slide. So I'll end my talk here and stop sharing the screen. Happy to answer a question, but all the best to everyone in Team ARASA. And I think we have a roadmap clearly in front of us. Thank you.
Yeah, thank you so much, Alankar. That was such food for thought, especially your last slide. And also just from our side, thank you so much for always being available to engage with civil society and all the investment, as you said, over the 3 years. You've actually invested quite a lot of your time in supporting our capacity to better understand these indicators, what the gaps are, what indicators exist, how they're being tracked, and also supporting and providing access for advocacy to the SADC structures. We really do appreciate the partnership. We can't do it without all the work of the partners and the solidarity and passion that the partners that we work with bring to the process and to these discussions. There's so much, Alankar, that's come up in your presentation and also in Maria's presentation that I would love to pick up on, but I am just looking at my watch, realizing that it's already 3 minutes past 4 and we only have until past. I would like to pose a challenge to Sally, my co-moderator, and her civil society panel, to please do justice by picking up on the various issues that may have come up in those 2 presentations. I didn't see any questions or comments coming from the participants, so that leaves more room for the panelists to actually pick up on a lot of what was shared. Sally, please introduce your civil society partners who will join you for the panel discussion.
Thanks, Felicita. And just to echo what Alankar has said, that the ARASA partnership and the work that you've done through Pitch and other opportunities has been really, I think, quite significant. So we've got a couple of people on our panel coming up. We've shifted the order of presentations a little bit, And what I want to do is to introduce them all to you and then hand over to our first contribution. And we've got quite a challenge ahead of us. Please don't forget to use the Q&A and use the chat to contribute your thoughts or your comments. First up is Futhi Precious Shongwe. Futhi is an HIV advocate, an activist. She works nationally, but also globally, representing Southern Africa. And her passion is really adolescents and young people living with HIV, and especially young women and girls living with HIV and affected by HIV. And she is a leader in many different aspects. She is, for instance, the secretary of the ICW Southern African Board. She sits on the Human Rights Panel in Eswatini, and she's also a member of Kango, where she represents young people living with HIV. Currently, Futhi is at the Eswatini Network of Young Positives as the program manager in the organization. So I want I'm going to hand over directly to Futhi, and then I'll introduce the other speakers as they go. Futhi will give her reflections on where we're at with achieving the targets, but also in particular what civil society needs to do differently to meet these targets. We heard earlier that 90% of young people should be being reached by comprehensive HIV prevention, and we know that is far from the case. So I'm going to hand over to Precious to tell us what needs to change. What do we need to be doing differently? You need to unmute yourself, Precious. Futhi, it is the constant refrain in these Zoom meetings. Eh?
Thank you, Sally, for that beautiful introduction. As you have highlighted, I represent young people living with HIV, girls and women living with HIV at nationally and global level. Looking at the presentations that have been laid before us, you can see that adolescent girls and young women are being left behind in terms of, especially when it comes to HIV prevention services and looking against the SDGs that our leaders committed to, especially when you look at the issue of gender inequalities and looking at the issue of socio-economic empowerment for young people living with HIV and adolescents living with HIV and young women. As much as some countries, a lot of countries have met the 1990 goal, but that doesn't mean we should celebrate. I would make an example of Eswatini, which has reached the 95. The question that is in front of us is the issue of how do we maintain that we don't move an inch from the goal. And the biggest challenge is that adolescent girls and young women not leaving behind young people living with HIV. In terms of HIV prevention services, especially accessing SRHR services, it is becoming a major challenge because you would find the notice at facilities or clinics saying youth-friendly services, but when you get inside, it is not a youth-friendly services. The attitude of our healthcare practitioners is still a major challenge for young people and adolescent girls and young women. The issue of SRHR services, like having a one-stop shop for young people, adolescent girls and young women, because right now you'd find that you come in to get your treatment in the facility and you've got a different sickness. Now you have to change and go to a different door. And you need to start afresh building a relationship with that particular healthcare work, which poses a challenge for a lot of young people and young women and girls. So if we get to a point where we can fix the attitudes, yes, we have made a tremendous achievement in terms of healthcare practitioners being really youth-friendly to young people, but we still have to strengthen that and make sure that we are able to maintain that. And looking at the issue of the infection rate during COVID-19. We are at a situation that we can no longer celebrate. When you try to go back to countries and look at the infection rate, we are now going up, yet we're trying to celebrate. And the fact that looking at the gender-based violence issues that are coming up during COVID-19. So that means what we've worked for, we are now lagging behind. We still need to do more investments in terms of funding, in terms of reaching out and making sure that SRHR services are within reach for what young people and adolescent girls and young women. In terms of policies, like we're mentioning the issue of age consent when you want to have an HIV test, we are still struggling as African countries because as adolescent girls or young people less than the age of 18 cannot go to access HIV services, especially when it comes to testing. And it's even a major challenge when it comes to SRHR, especially when you want to do family planning, because we still want young people to maintain that they are not having sex. As much as I am a fan of abstinence, but we cannot run away from the fact that young people are having sex, and we need to make sure that they are always protected and they have all the SRHR services within them. And we as civil society, we still need to play a major role when it comes to advocacy around stigma and discrimination. It is really a threat when we talk about adolescent girls and young women, because as much as the statistics shows that we have made a drastic improvement, but then you start counting the number of years trying to deal with the epidemic. We are supposed to be at 0, but looking at 32%, that's quite a huge number. Even if it was 2%, to us as adolescent girls and young people, that's still a huge number. We are seeing government not even accepting the U is equals to U concept, because they feel like young people, adolescent girls and young women will be having sex anyhow. And in most African countries, we haven't even we can't even publicly talk about it. When we talk about it, we cannot talk about you is equals to you as an open thing. It's something like we should talk about on the side. So yet that's one component that can help us to decrease the stigma and discrimination amongst young people living with HIV and adolescent girls and young women living with HIV. Funding in terms of advocacy is really quite a huge challenge. Even when we have to do advocacy in terms of policies and spaces, we are seeing some bit of acceptance in terms of young people being involved, but we still need to be a bit aggressive in ensuring that young people are empowered to go and claim their space. We need to make sure that adolescent girls and young women also can claim their space, go to meetings, go and demand services or accountability to spaces that we have not been invited to, so that we can be taken seriously. Also, we still have a tendency of, when we do programming, we still sit without having the targeted population on the table. We are planning on other people's behalf, and we say this is what they want, when they are not on the table to say this is what they want. If we invite the targeted group, we just make sure that there are rubber stamps to say to the donors, yes, adolescent girls and young women or young people living with HIV, they were there. When you try to go back, they didn't have even enough information. What are they supposed to do in that particular platform or meeting? What are they supposed to contribute? Some terminologies are very difficult, they can't even understand. So we still need to make sure that we involve young people and we respect the voice of young people living with HIV, adolescent girls and young women. In terms of advocacy, we still have a drastic role to play, and we require a lot of funding to ensure that we meet our 2030 goals and maintain all the efforts throughout all these years. Thank you so much, Sally.
Thanks, Futhi, and you were right on time there. Well done. Well done. Just want to point out some of the things that you mentioned specifically, Futhi, because I think that they might help the next speaker also to shape their input. I also want to acknowledge two comments in the chat box that I think are relevant. So one is around somebody has Genevieve, for instance, that we also need to focus a little bit more equally also on boys. And sexual and reproductive health services without parental consent is a regional issue and needs to be addressed. Thank you for that, Genevieve. Kennedy has also pointed out that there are projects where communities are collecting data on specific key populations, but these populations and the data are not integrated into national health information systems. So we need to address that as well. We also have another, so I think your comment around representation, the demand for representation for young people without any support for preparation and for the advocacy and work it takes to prepare young people to be activists and to advocate in platforms that they're given access to, I think is a really important point. We can't make sort of empty representations. We must support young people to access the information and the tools they need to be activists and to participate. You also mentioned the sort of paying a little bit of lip service to the idea of youth-friendly services, and that's often not the reality. And the funding issue is really important. 2% of funding goes to programs targeting key populations, and yet more than half of the new infections are among key populations. So with that, I'm going to hand over to our next speaker, who is Anil Padavatan. I hope I said that correctly, Anil. You will correct me if I didn't. Anil is a health and human rights activist in the field of HIV and human rights, as well as access to healthcare. He has worked for various human rights organizations, including the AIDS Law Project and the Southern African HIV Clinicians Society. And Anil is currently the Health Advocacy Officer and Assistant Programs Manager at Gender Dynamics, which is the first organization specifically registered for trans people on the continent, and also for gender diverse people. So Anil has got a particular interest in improving access to gender affirming care for trans people and gender diverse people, and we'll talk a little bit more about ensuring that structural barriers and HIV prevention are integrated into advocacy. But Anil also has a specific interest here in data and the generation of data, because there's so much missing data about trans and gender diverse people. So I want to encourage Anil also to speak to this issue. When we heard the presentation earlier by Maria, we also heard that 90% of key populations should be covered by HIV prevention services. And we also heard that there should be zero discrimination, and we certainly know that this is not the case. So let's talk a little bit more about that. Anil, I want to invite you to unmute yourself and make your contribution.
Hi, thanks so much. Hi, everyone. It's great to be here today. So I'm Anil. I'm a transgender man. I work with Gender Dynamics. And I want to kind of problematize some statistics here today. Because if we're talking about accountability, we first have to look at what is being counted exactly and who is doing the counting. So, for example, you've got a statement saying that there are countries that are not criminalizing transgender identity. So you're not criminalized on the basis of the fact that you're transgender per se. The problem is that when you start kind of delving into the situations there, we know that in the Southern African region, gender identity and sexual orientation are often conflated. So there's the reason why there's no laws specifically targeting the transgender community is that there's not a lot of recognition of the fact that there is a transgender community, and people who are transgender are usually included in in issues around sexual orientation. So they're seen as just another part of the gay or lesbian community. And that means that in countries where same-sex relationships are criminalized, trans people are generally fall under that legislation and are criminalized as well. It means that where you've got countries that are criminalizing, have specifically laws criminalizing impersonation, people who are assigned as male at birth and who are living in a female identity are criminalized. And where you're talking about situations where you have countries that have dress codes, which are stipulating that certain people can't dress in a certain way, where women are not allowed to wear pants, etc., then trans people are criminalized. So criminalization happens, but not necessarily under specific laws. And then we know that there's also, as Alanka was talking about, we have these, where even where there's not specific legislation, we have violence which is not prevented by the state, where people are subjected to violence, to harassment, to discrimination, and that is then not prevented by the state. There's no laws that are preventing that kind of discrimination. There's no follow-up by the police. There's no prosecution in the courts. That then becomes an institutionalized form of violence and discrimination. So that's already problematic. Then we have the question of where are the stats on the trans community, and why is this important? So first of all, one of the reasons why we know that why this is being flagged as a key population is we know from research that's happened in the first world, in the global north, we've seen that trans women of color, and I'm talking specifically Black trans women, have incredibly high burden of HIV. So this is a population that's extremely vulnerable to HIV. And the reason for that is the intersectionalities. We're looking at people who are discriminated against because of their gender identity, because they are women and presenting as women, and they're subjected to gender-based violence, and because they're Black, and we have institutionalized racism in our societies. And all of these then form these layers of discrimination that put people at risk and make sure that these populations are under a heavy disease burden. And so we've got very limited data at the moment on HIV in the trans population in Southern Africa. There's been a couple of studies, and they're reflecting the position from the global north that Black trans women have got incredibly high rates. Close to 50% of Black trans women are living with HIV, and that's a very high level. So how do we start addressing that? So we need to look at the barriers. Why are people not accessing services? Why are they not accessing testing? Why are they not accessing treatment? Why are they at risk in the first place? And all of these come down to the kind of institutionalized discrimination within society. And it creates a negative feedback cycle. So you've got someone who is presenting as a woman, living as a woman, dressing as a woman, and they are scared to go into a clinic because of the discrimination that they face. So a lot of trans people don't go to clinics at all. They get their primary healthcare through pharmacies because of the fear of stigma and discrimination when you go into the healthcare system. And a lot of trans women are vulnerable to HIV in the first place because of the barriers around access to employment, access to education that come with being trans. And that makes you dependent on intimate partners. And when you're economically dependent on intimate partners, you have barriers to access to negotiating safe sex. So these all create a negative feedback cycle. The more discriminated you are against, the more at risk you are, the less likely you are to seek help in the health system, the more likely you are to face discrimination in the health system, the more likely you are to be vulnerable to HIV. So we need to start looking at how do we creatively break these negative feedback cycles and start creating the positive feedback cycles. So obviously we need research, we need data, that's vital. And we need local research and data, we need Southern African studies, and we need funding for that. And then we need to look at how do we disrupt these cycles. That's why I think pandemics in all of their horror, present opportunities for us as well, because it's a disruption of our systems. And when the systems themselves are discriminating and are oppressive and causing violence, these disruptions can give us an opportunity for activism. And so we've seen recently with COVID, the massive impact that it's had, and it's had in the same way that HIV has an impact on the trans community, it's had that same devastating impact on COVID has had the same devastating impact on the trans community, especially trans women of color, because of those intersectionalities. And especially based people, especially sex workers, all of the communities that are facing these barriers. But we can look at, once our health system gets disrupted, how can we then jump in and improve and start putting in interventions that start taking care of those barriers. So if access to healthcare facilities is a barrier and COVID allows us to do telemedicine, that's an opportunity. If COVID allows us to start doing community-based health delivery, that's an opportunity. If COVID forces us to start looking at pharmacies as primary healthcare deliverers of primary healthcare services, that's a big positive. And we can start looking at how do we leverage these opportunities that these devastating pandemics can actually bring to our societies, and be really creative about it, because people talk about going back to normal, and the old normal never worked for the key population. So how can we make sure that the new normal does go some way to start addressing these? I know we're under pressure. There's a lot more I can say, but I'm going to leave it there.
Thanks, Anil. Hopefully we'll have a chance to bring you back in a minute. Thank you so much for those comments. I think you made some very important points about trans people not being counted, being conflated, being criminalized, and having this sort of combination of being hyper visible and invisible at the same time. I think that we absolutely need to critically engage with data, and the Kennedy's comment, I think, comes to bear here. Also in getting ethical approval for studies and getting communities to lead on information and data. We did hear earlier that 30% of services are supposed to be community-led at this time, so we really need to make sure that we do that. And I liked what you said around disruption, and there are opportunities in disruption, and that's a great segue to introduce the next speaker, who is all about disruption. Ishtar Lakhani gave me the permission to adjust the biography provided, so I'm going to do just that. Ishtar is a creative activist and is really great at linking activism across social justice movements, and I think that the previous conversation about disruption is the perfect entry point for Ishtar, who described herself as a free radical, collaborating with social justice movements and providing support to strengthen approaches to human rights advocacy. So Ishtar, drawing on your work, let's talk a little bit about supporting social justice movements and talking about the creative ways we can make connections more broadly and join up some of these things that we're talking about, especially what opportunities disruption provide for key populations to get some change. Thanks.
Cool. Yep. I'll try and keep it as short and sharp as humanly possible. So thank you very much for the opportunity. Yeah, I do want to talk a little bit about creative activism and using it in disruption, as well as just reflecting on a lot of the conversation today has been about data and information. And my question is going to be, how do you use that in your advocacy? What is the most effective and creative ways that we can use this information in our advocacy? And usually I no matter where I'm working, I often start with the question, what made you care about human rights or HIV activism or trans advocacy or sex worker rights? And I listen to what hundreds of activists and social justice movement organizers have said. And often what they tell me is really deep, moving stories of what made them care. They didn't wake up in the morning and decide to fight for the rights of vulnerable groups. Something happened in their life that made them care enough to act and often dedicate their lives towards this particular struggle. Very rarely do I get the response of, you know, I signed this petition and then I was moved. I was so moved that I had to kind of jump into action, or I watched this webinar and that really lit a fire under me to dedicate my life towards HIV activism. Not discounting these things, but it's never the response I get. What I do get is people will move to care. And so for us as people that are social justice activists who focus in advocacy, that is essentially what we're trying to do. That is the core of our work. Our work, what was mentioned a lot in many of these presentations, was around stigma and discrimination. What we're trying to do as people who do advocacy is move people enough to change the way that they behave, to change what they care about, to change what they prioritize. So at the end of the day, what we're trying to do is develop strategies to move people, not necessarily policies, because those policies are rubber stamped by who? People. You often get this, the government, the police, the criminal justice system. But at the end of the day, there's individuals who are pushing those systems. There's individual police officers that come from our communities. The nurses that stigmatize are also the nurses in our community. So my challenge is, how do we then develop our advocacy in a way that targets people and moves people, that will then forward our advocacy agenda? And how do we reach those people? And what are the things we need to do to reach those people? So now that we know that we need to reach people and move them to care, the question is how? And this is where the idea of data and information comes into play. Often in the work that I do, I often rant to myself going, if only they knew the information, they would make the right decisions. If only policymakers knew why they need to decriminalize sex work, we would have decrim. And the problem that we encounter with now knowing that we have to target people is that evidence is not enough. Knowing is not enough. This idea of, if only we just raise awareness and we create a wonderful fact sheet and we give that fact sheet to the policymaker, they will read it and make a wonderful, rational decision and do what we say you should be doing, especially because, you know, it's human rights. I wish this was a world we all lived in, but sadly, evidence is not enough. Evidence is not enough to move people to care. So my provocation is always around, okay, now that you know, how are you going to convince? How are you going to tell a compelling narrative? How are you going to make sure that the people who are most affected are the ones that are telling those narratives? And so that's always been the difficulty that I've had in my work, specifically around the decriminalization of sex work. I talk about that a lot because I think it is a very profound and key example of the intersections of so many kind of vulnerabilities and oppressions, but it's also a key narrative that needs counteracting, because everyone here, the minute you talk about sex work, Hollywood stereotypes of the seedy underbelly of prostitution is always the narrative that is perpetuated. So whenever you try and do advocacy or engage in a conversation, this is what is going on in the background. This is what's going on in the policymaker's mind when you're trying to talk about access to stigma-free healthcare, very sensible things like maybe it's a really bad idea for police to confiscate condoms from sex workers. In the back of their mind, there's this narrative playing of the seedy underbelly. And so for me, it's how do we take all that data, all that information, and make it, for lack of a better word, package it in a way that actually is compelling, that actually triggers people's empathy, for lack of a better word, because that's what we're trying to do, is create a kinder, more compassionate, more just world for all of us. And some of the best examples of, for example, anti-stigma campaigns never use the word stigma and discrimination in the campaign whatsoever. Some of the most powerful acts, I mean, off the top of my head, I can think of, there was this Australian magazine that produced the entire magazine using the blood of HIV positive people. And that was fascinating for what it did for discussions around stigma and discrimination, but never using the word stigma and discrimination. It really made, it was a visceral thing that made people kind of come to terms with, am I stigmatized? What is stigma? What does it mean? And it made it very personal. So my idea is, and my provocation for this discussion is, and for people to think about, is how do we take all this information we have? How do we make it kind of accessible to people in a way that can really move them to care about what we care about? Because at the end, that's what we're trying to do.
Thanks, Ishtar, right on the nose there for your time allocation. So I mean, what you're basically saying is we have to review our advocacy. We have to look at how we're using data to speak more directly to the narrative that sits inside someone's head. We have to make them care. We have to make it personal. And that requires a little bit of creativity. Dennis, you asking about the slides, they will indeed be shared, and so will the recording be shared. I want to end off with each of the speakers. Just a really one sentence. We often talk about how our advocacy needs funding. We talk about how we need to shape our advocacy. We talk about how we need to inform our advocacy with data to make sure that we're shifting the narrative. But I want to ask the panelists in the room, who is opposing us? Do we know who our opposition is? Because if we're not moving forward, it's because we have active people who are opposing our messages. Do we know who those people are? Do you know who those people are? And have we thought about that enough? So I just want to ask that one question, and I want a sentence from each of you about who you think is our direct opposition in the work that we need to do to reach our targets. So I'm going to start with Futhi, because we began with you in the first place. Futhi, if you're still on the call, can we hear from you?
Yes, Sally. Usually I believe in taking responsibility in the fight against HIV. So I would say, as young people, adolescent girls and young women, we are opposing ourselves because we have the strength, we have the power, and we can make the change as long as we put an effort to it and demand the space, because the space is there, it's rightfully ours. We just need to show up and demand for it.
Thanks, Futhi. You've got justice on your side. I want to call Anil to answer the same question. Anil, if you're there, can you unmute yourself?
Hi. So, yeah, as Futhi said, I think it's not useful to create a kind of us and them narrative. I think that kind of goes against what we're trying to do. I think we've got a lot of work in public opinion to do. And I wouldn't say that that's the enemy, but I think that's where a lot of the work lies. As Ishtar was saying, and I kind of take a more cynical role. I think there's a lot of politicians who do care. When I speak to, we talk about the government. When I speak to a lot of people in government, they care. They're people who are in government because they care about human rights. The problem is that they're often reluctant to act because they're concerned about their political popularity because of public opinion. And I think we need to change the narratives and look at how we portray whoever we're trying to work with, and I think it's very important that as we said, it like kind of have a lot of the speakers have said, have a bottom-up approach and not a top-down, where we can't represent anyone. What we can do is create some space and get some other voices heard, and I think that's very important. make spaces for those voices to be heard, and try and get that to have a critical mass where public opinion changes. And I think that's where the big battle lies. That said, I think it's often when we talk about we need to speak truth to power, I think that's important. On the other hand, speaking money to power also helps as well. And I think this is where research comes in very powerfully. If you can tell the Department of Health how spending money on gender affirming healthcare is going to help them meet their targets in terms of HIV prevention, then you're much more likely to spend that money. So I think whilst we're speaking truth to power, we also need to be a bit strategic and speak money to power as well, and speak public health to power, because often that's where the change in public opinion comes. There's a lot of healthcare workers who've felt over the years very uncomfortable about treating people who were gay in public health clinics, but because it was a public health emergency and HIV was a big priority, they got over their own personal feelings about this and started delivering services. And we can do the same with all of our key populations. We've just got to use our ends. And if public health is an in, we don't lose sight of the human rights approach, but that's our in and we use it.
Thanks, Anil. Ishtar, what's your opinion? The fight for decriminalization of sex work has been continuing for, forever, it seems like. Who's actively opposing us, and how do we address this issue?
I mean, it's a very difficult question. Can I not just say that the capitalist patriarchy is our opposition? I think
you can.
I mean, I think it encompasses. I think it encompasses a lot of what we're all trying to fight against in its entirety. But I think distilling kind of the impacts of the capitalist patriarchy, where, for example, this idea of how change happens and what affects change. I think that's part of our opposition as well. The kind of not brainwashing, but the kind of very narrow understanding of how change happens, and it only happens in a particular kind of way through particular institutions that we then have to fight and change, even though they were never designed to work for us in the first place. As well as, I have a cat that's trying to do a cameo. As well as how we can then impact that change. So I really think we need to kind of evaluate what is change, what is the change we'd like to see, and how do we implement those change in our communities. Change doesn't necessarily have to be implemented at a state level or an institutional level or a criminal justice system that was never really designed to work for women or people of color or sex workers. So yes, capitalist patriarchy in a nutshell.
Okay. Yeah, that makes sense to me. Thanks, Ishtar. I'm gonna hand over to Felicita here, but I just want to summarize by saying that we did talk a lot about data, but we did have a caveat on data, in that we're recognizing that data itself isn't what changes people's minds. We have to package that data that speaks directly to the narratives that people hold, the prejudice that people hold, their socialized notions that people hold. And I think it's interesting that we also mentioned public opinion. Public opinion is often a big stumbling block to change. If politicians feel that they'll be unpopular for making a particular decision, even if it's supported by evidence, they need public opinion to support that change. And just encourage us to think a little bit more about how we are advocating for change on HIV prevention and joining up our struggles a lot more. Thank you, everybody. Thank you especially to the panelists who spoke, and for those who were listening, thank you very much. I'm going to hand over to Felicita.
And thank you, Sally, for being such a phenomenal moderator. I particularly appreciated your summaries at the end of each of the interventions and how you've just pulled it all together, because it means that I don't have to do that. And it means that we can save on time. But thank you so much. There was such a fascinating conversation. I thoroughly enjoyed that. And although we've heard a lot of this before and we've been frustrated with the data issues, etc., there's always a fresh spin when you invite new voices to these conversations, and especially voices that we as ARASA and the Pitch partners have not engaged with. So I particularly appreciate the voices of Precious and Anil. We've engaged with gender dynamics before, but Anil, your perspectives were so refreshing. And also Ishtar, just having engaged with us in this way and sharing so much of your wisdom and your experiences around creative activism. Thank you, thank you, thank you so much. But I am not going to take too much time before we come to the end of the webinar, because we are already 15 minutes over, and it's been a very intense conversation, and it's been a lot of information that we may all want to mull over. But before we move to the end of the presentation of the webinar, we actually wanted to check back in with everyone who has managed to stay with us thus far. And we do appreciate the fact that you have stayed with us to this point in the agenda. As I mentioned previously, we want to do a few polls using the Zoom poll platform, just to check in with where you are at the end of this conversation. And the first thing we actually wanted to know, it's also going to help us track part of how we reach people and where people get information about our webinars. So the first question we have is, how useful did you find this webinar to understand the 2030 targets? So the poll has popped up on your screen, and it would be great if you could just click one of those options. You found it very useful, you found it somewhat useful, not useful at all. This is anonymous, we won't know who clicked what, but also we have very thick skin, through all these years of engaging in advocacy and activism, we have built up fairly thick skin. So you can be brutally honest about how useful you found this webinar to understand the HIV prevention targets. So feel free to answer that first question. The second one is, do you feel more confident now in your ability to advocate for government accountability for meeting the 2030 targets? So regardless of what level of knowledge, understanding, experience, etc., you came into this conversation on, do you feel now even more confident in your ability to advocate for government accountability in regard to the 2030 targets? And then lastly, we just wanted to know how you found out about this webinar. So it would be good for us just to keep track of what platforms are useful for ARASA in reaching our partners. So it would be great if you could respond to those questions, and maybe we can give it another minute or so. Hejin, just a quick question. Are we going to see the results of the poll right now? At the end of the polling?
Yes.
Okay, so once everyone submitted their responses, you will then click something that brings us the results.
Yes.
Is that how it works? Okay, great. Okay, so we'll just give it a few more moments, and then we can get the results of the poll. I will actually continue with my remarks, which are not much, and are basically just an opportunity to say thank you. Actually, before I do that, let's just quickly look. 88% of people found the webinar useful to understand the 2030 targets, and 13% somewhat useful. The 88% again feel more confident, and 13% somewhat confident. And most people saw the information about the webinar through direct email invitation. Mailing list 13%, Facebook and other also 13%. Thank you so much for participating in that poll. We really do appreciate it. But with that, we've come to the end of our webinar titled Ending AIDS is a Public Health Threat by 2030, Moving Beyond 2030 Towards the 2030 Targets. As mentioned previously, this is the first of 3 webinars we will be hosting. specifically on HIV prevention, with a special focus on removal of structural barriers. So if you enjoyed this webinar, please look out for other announcements for the upcoming webinars, which will happen, I believe, in 2-week windows. But we will advertise those once again on the platforms through which you learned about this webinar. Please feel free to share and circulate those announcements in your network. We hope to engage with you once again in a few weeks. In the meantime, you can also visit the ARASA website for resources on advocacy for HIV prevention. It's www.arasa.info. We have briefs, advocacy guides, scorecards, or information on the scorecard, other advocacy tools such as calls to action and statements that have come out of previous civil society consultations that may be useful for your advocacy with your government or other stakeholders. But before we end, I would like to thank very much everyone who has joined and stayed with us till the end of this webinar, but particularly the presenters, Maria, Alankar, my co-moderator, Sally, and the panelists who shared so generously their experiences and perspectives on the various issues that we discussed. I also want to thank the ARASA team who has worked behind the scenes, not only to pull this together, but also to make sure that the webinar went as smoothly as it did. Also to the participants who have joined, but particularly those who are ARASA partners and who have actively already been engaging in advocacy for the removal of structural barriers. We appreciate your continued solidarity. I also want to thank Pitch and UNAIDS for their continued support and collaboration. With that, thank you very much for joining us and enjoy the day further. Goodbye.
Bye, everyone.
Bye.